Chapter 12 in the Reimbursement and Revenue Cycle Management book is about coding and clinical documentation integrity management. Here are our learning objectives. There are 16 questions from Chapter 12. This module also includes Chapter 13, and there are also 16 questions for a total of 32 questions. So, just kind of as a reminder, coding begins with documentation. Our CDI is our clinical documentation integrity. It looks at a review of our health records to improve the quality of the documentation. Coding and CDI involve diagnostic and procedure codes, and these directly impact our reimbursement amounts. So our coding management, coding at the highest level of accuracy and efficiency is key to revenue. So coding management is responsible for organizing the coding process so that healthcare data can be transformed into the meaningful information for claims processing. Now this is going to be carried out by our coders, but we'll also have inpatient, outpatient coders. We'll have a coding manager, and then we'll also have people that are analyzing the quality of our data. So our coding manager is going to make sure that we hire qualified staff. They ensure proper tools are available, our code books, our up-to-date guidelines, conducts performance assessments where we're monitoring and looking to make sure that we are being effective when we code. And then they also are responsible for providing that continuing education. So with our coding, we're going to have 3 levels. We have the entry level, the experienced coder, and then the expert coder. So the entry would be our beginning coder. They probably just recently completed a program somewhere. They may not be credentialed yet. Experience, they have at least 1 year. Most have a coding credential. Most are proficient in ambulatory same-day coding. They usually have limited exposure to inpatient, and they can usually meet productivity and accuracy. Now, our expert coder has mastery in multiple code sets, and that's because they probably have several years of experience. So they are more productive, more accurate. They usually have more credentials, but expert is multiple code sets. On the right-hand side there is our credentials that we can get for coding. In your book, Table 12.1 takes you through a summary of each of those. You can go in and you can look at those. Usually what I say is pick the one that's going to meet what you are doing as a job. Now, as we progress, this is kind of the layout of how it goes, and this is figure 12.2. It's on page 229. We start off as that coder trainer. Then we can become an outpatient coder. They usually are doing emergency and clinical records with about a 20% review for accuracy. Then we have our inpatient coder, our coding specialist, our lead coder, our coder supervisor. They're usually the ones that are performing the accuracy reviews. They compile productivity reports, and they maintain our coding policies and procedures. And then we have our clinical data analysis. So it's critical to determine that people are placed into the appropriate position. Ensure that the coding professional is prepared for that role. Ensure that the role is challenging for the coding professional. If you're overqualified, you may get bored. It may lead to people leaving because they're just not engaged. And remember that not all coding professionals want to have a management responsibility. So many coders just simply want to code. Now, as far as some coding tools that we have our facility-specific coding guidelines. These encourage complete documentation that support consistent code assignments. It serves as a training tool for newly hired coding professionals. So this is tools that the facility can decide to use, as well as our coding guidelines that go along with our CM and our PCS and our CPT. Now, what will we see in these guidelines is listed on page 229. There's some bullets there. In our guidelines, it may state when to query a physician for clarification, what procedures are soft-coded at that facility, what procedures are hard-coded, documents that are appropriate to use in the coding process, the appropriate use of unlisted CPT, and then the appropriate use of CM status codes. So that's just some examples of some things that might be facility-specific. Next, we have our coder and abstraction platform. These are coding tools that facilitate the incorporation of coded data into the EHR. So this is what inserts that coded data into that EHR. Most facilities have an encoder that promotes consistency and efficiency. Our encoder software helps to facilitate our diagnosis and procedure codes based on those coding rules. It makes the coder go through the prompts. If you think about 3M, it gives us prompts where we're having to put in information, and then that decision is made for MSDRGs and APCs that help with the calculations. Now, in a doctor's office, they may not have as many choices with this electronic software, so it leads a little bit more toward inpatient being more successful. Last, we have our computer-assisted coding known as CAC. This searches and evaluates the documents to assign a list of codes, both diagnostic and procedure codes. And then our coding professional comes back and applies the guidelines to select the codes. So this tool improves code efficiency. It supports code accuracy. It can have a long implementation period. One thing about it is the more it's used, the more the system is used, the better it gets, because it starts looking at what that coder is pulling out and using, and it kind of adjusts to that, kind of like a robot type thing. So our basic CAC process, and make sure that you know these. CAC searches and evaluate. This is actually, let me tell you what page this is on. This is on page 231, figure 12.3. So our CAC searches and evaluates our clinical documentation. It then produces a list of diagnosis and procedure codes. And then the coding professional applies the conventions, guidelines, and regulations to select. So again, the CAC is not replacing the coders, but it is assisting coders to help pick the right codes for that documentation. One thing to remember is this is usually not set up for our facility guidelines, so we may have to make sure that we're meeting those facility guidelines. And then, like I said, it does get better the more that the CAC is used. But do know those steps. So on our performance assessment, this is where we're going to evaluate the coding professional's performance. It should be set up on a ongoing basis. And there's 3 criteria that we're going to look at. We look at productivity, accuracy, and then how appropriate are our queries. So our productivity is basically the number of medical records that are coded per hour. Our accuracy is, are we submitting error-free and complete codes? And then queries, are they being used appropriately? Are they free of errors and respectful? Now, from some of your other courses, you know that a query is a communication tool that's used to obtain documentation clarification from a patient document. And let's talk about each one of these. So let's talk about productivity a little bit more. Now, this is, again, that expected number of medical records that a coder is able to do. It is sometimes difficult to determine that because some facilities may be coding different charts. So an inpatient chart may be more information than an outpatient or an ER or something like that. So sometimes it can be challenging. We can develop our own standards that we can use to set up and look at those factors. But basically, we have three areas that we look at. The first is the facility. We're looking at the number of beds. Is it a teaching, and is it a trauma? So some of those areas are going to take longer to code because they're more detailed, and that needs to be taken into consideration. Our coding professional influencers is our education level, credential, and years of experience. Of course, a brand new coder is not going to be as productive as that expert coder who has more years of experience. So we need to keep that in mind when we're looking at those factors: education, credential, and years of experience. Then we have our medical records. Think about our case mix. Remember that case mix is saying how much resources we used, how complex is that. So the more complex, the longer it's going to take to code it. And then the length of stay, the longer that patient has been in that facility, the more information that's going to have to be looked at, so the longer it's going to take to code. Now, you can calculate coding productivity. So let's say that I know a patient or a coder is working 400 minutes in a day, and it takes on average, let's say, 10 minutes to code a chart at that facility. So if I wanted to know how many should they be able to do, if they're working 400 minutes, it takes 10 minutes. That's simply to divide that 400 by 10. So they should be able to do, what is that, 40? Let me double check my math. 400 minutes divided by 10 minutes for each one. So they should be able to do 40 charts in a day. So you just simply divide the total minutes by the minutes that it takes to code, and we can kind of determine how many should be done. Now, a little bit more about accuracy. Accuracy is, again, making sure that all of our codes are current, correct. And the four things that we look at with accuracy are our diagnosis codes, our procedure codes, and our modifiers for our outpatients. Remember, we have modifiers for CPT and modifiers for HCPCS. So those are our codes. We've heard of them. We've talked about them. Next is a new area. It's called a discharge status code for inpatients. A discharge status code simply is a code that we put on our claim form that tells where that patient is going at the end of their stay. So on page 233, there's some bullets. So if I put a 01, they're being discharged to home. A 03, they're going to a skilled nursing facility. 06, they're going home, but they're going to have home health. 07 is they left against medical advice. And a 20 means that they expired or they passed away. So those are our discharge status codes. So diagnosis, procedure, modifiers, and discharge status are what we look at when we're looking at accuracy. The best practice that we can have is a 95% accuracy rate. Now again, we adjust that for trainees and then for our experts. And we're going to monitor until we get to that acceptable accuracy rate. Most facilities keep statistics where they can go back and pull and look and see what the rate is. Next is our query appropriateness. And remember that query is where we're asking those questions about clinical documentation. Sometimes it's the CDI that's doing that, and then sometimes it's the coder. It may be required to have questions answered before the discharge. And then again, that manager can use criteria to measure if the query is compliant. So there's some criteria. It's clear, concise. It contains clinical indicators. It presents only the facts, identifying what clarification is required. Remember, we're not to lead the physician. We're simply asking them to clarify. It does not include the impact on reimbursement or quality, and then it aligns with the facility or practice query policies and procedures. So figure 12.5 in your book on page 235 has some clinical indicators, signs and symptoms, suggesting the diagnosis, vital signs, abnormalities on physical exam, abnormal lab and imaging. Another area is treatment and monitoring are the medicines, infusion, transfusion, therapy, planned workup procedures, links, cause, and effect. And then the related conditions are risk factors and comorbidities. And then the examples on 12.2 and 12.3, they show the difference between a leading and a non-leading. And these are on page 235 and 236. So example 12.2 on 235 says, a patient is admitted with pneumonia. The admitting H&P reveals a white blood cell count of 14,000, respiratory rate of 24, temperature of 102, heart rate of 120, hypotension, and altered mental status. The patient is administered an IV antibiotic and IV, I think that should be fluid resuscitation. So leading would be the patient has elevated white blood cells, tachycardia, and is given an IV antibiotics. Are you treating sepsis? Non-leading would be, based on your clinical judgment, can you please provide a diagnosis that represents the below indicators, elevated white cell, tachycardia, and IV antibiotic administration? In 12.3, a patient is admitted for a right hip fracture. The H&P notes that the patient has a history of chronic congestive heart failure. A recent echocardiogram showed left ventricular ejection fraction of 25%. The patient's home meds include metoprolol XL, lisinopril, and Lasix. Leading would be, please document if you agree that the patient has chronic diastolic heart failure. Non-leading, it's noted that the impression of the H&P that the patient has chronic congestive heart failure, and a recent echo noted under the cardiac review reveals an EF of 25. Can you please further specify the type of chronic heart failure? And it gives you the options to do that. So just remember that those queries are supposed to be those that are non-leading queries. Now let me say, because I skipped over one of these. Let me make sure I hadn't skipped any more. Over on page 232, 12.1 is some examples of calculating the productivity. So 12.1, 232, and 233 is calculating productivity. So there's a couple of other examples other than the one that I gave you. You can see it written out. So again, remember, don't lead. AHIMA does provide a lot of query tools, and a lot of time your EHR will also provide query tools that can be used to help with better queries being done. Now next we have coding dashboards. With our coding dashboards, they have key performance indicators, and those are called KPIs. This is where we can look at the actual unit, not necessarily the individuals. There are 6 areas that we look at with these, and they are listed here and also on page 236, figure 12.6. And it's important that you know these 6 as key performance indicators and be able to tell what each one is. So the first one we have there is CMI, and it measures the effectiveness of the coding management. Remember that our CMI is based on our MSDRGs, and we use that for our inpatient. It helps to look at our resource use. A shift in the CMI up or down should be reviewed, and it can be an issue with coding performance, but it may also be just simply a fact that the number of procedures are changing, if we've changed services, or if we've changed equipment. Going to the right on that first row, the next one is a denial rate. The denial rate measures the ability to comply with documentation, coding, and billing requirements. So if a reimbursement is declined, then it's going to show up in a denial rate. This can be because we failed to submit documentation or medical necessity. We didn't meet guidelines. Remember that this is a denial when the appeals have been exhausted. Next, we have our clean claim rate. This measures the ability to comply with billing edits. Edits are designed to promote correct coding. The editing system a lot of times is used by the MAC to make sure that the claims are all accurate. On the second row, we have the DNFB. This is our discharged, not final billed. This measures the health of the claims generation. It can be days or dollars. Coding productivity decreases, then that DNFB is going to go up and vice versa. You need to look at the DNFB before you start letting people off, or if you have a lot of people that are sick, because that can really impact your reimbursement. Next, we have the Pepper Metrics. This is our program for evaluating payment patterns, electronic report. This is a metric that's used to identify billing patterns that are different from the majority. To measure accuracy, sometimes we're looking at CMS and statistics for discharge, and they may look at areas that are at risk for not being paid or at risk for items that may be overcharged or undercharged. So on page 237, there are some examples. Sometimes they look at respiratory infections, septicemia, ventilators, and then cardiovascular procedures. And then our last one is our CC to MCC capture rate. This is a metric used to identify secondary diagnoses issues. So this is looking at those cases where we may be having an issue with our secondary diagnoses codes. So our capture rate, this is an example. It's on page 238, figure 12.7. So if we're looking for certain MSDRGs, we can look and we can see 344, 345, and 346. We see that the number of each one of those that can be done. So we can kind of monitor that over a time. And then the second part of that looks at the percentage. So it looks at the number of cases divided by the total number in the cases and multiplies it by 100. So this is just a way that we can see if we're capturing that rate. Don't get too hung up on that. You're just going to add those together and look. So in this case, it's got a 71.4% capture rate. So we probably need to look at that and determine why it's being missed. This is a sample dashboard for coding. This is on page 239. It covers all 6 of those areas. You've got your CMI, your denial, your clean claims, your DNFB, your PEPR, and then your CC, MCC capture rate. This is just a form that can be used to show trends. It displays those key metrics. It's a way to show your revenue team and your leadership what's going on in the coding area. And that's with the use of that dashboard. Next, we have our coding compliance. And this is kind of a unique thing that needs to be done because it focuses on those regulations and guidelines and what does our coding team need. So it looks at 3 areas. It looks at policies, procedure, education, training, auditing, and monitoring. So in our policies and procedures, we should have a guideline or a policy for each of our tasks to ensure that all tasks are being included. Coding compliance plan is essential. Now on page 240, there's a list of the things that are commonly included. Physician queries, coding diagnoses not supported by medical documentation, upcoding, unbundling, coding medical records without complete documentation, how to assign a discharge status, how do we use the encoder, and how do we use the CAC. So those are things that would be in our policies and procedures. There may be others. Next, we have education and training, and this should be a continuous process because remember, all of our codes are constantly updating. We talked about in a previous chapter how a lot of our insurance companies, Medicare, it's changing frequently, so we should be keeping up with that through education and training. It should include revenue compliance, documents, special attention for new coders, especially because those new coders may need more education than an expert coder because they're still in that training process. Now on page 240 again, there are some things that would be included. Guidelines, our national coverage determination, Medicare claims, the official guidelines for CM, PCS, CPT, HCPCS, any quarterly, yearly code changes, quarterly, yearly prospective payment changes, anything with the Office of the Inspector General, and then our National Correct Coding Initiative. And then lastly, we have our auditing and our monitoring. This is where we gather information about our department. We're looking, are they compliant with those policies and procedures? We can use internal and external benchmarking to help determine compliance. Now, benchmarking is usually where we compare our performance to a standard that's at other facilities. As far as internal, that's usually going to be your manager. External is where we have an outside group that comes and looks. The advantage to the external is that we get a non-biased view of what's going on in our department. The OIG, it releases a resource guide to help measure that program effectiveness for your coding compliance plan. All right, so before we move on to the next section, let's look on page 241 at the check your understandings. So number 1 says describe the CCS credential. So a CCS is a certified coder. This is through AHIMA. It's usually for somebody that has ICD, CM, PCS, CPT. What is CAC? CAC is computerized assisted coding. Remember that it takes that information out of the document and it translates it, but then that the coder must come back and pick and choose what is the correct codes. which coding KPI measures effectiveness of coding management. So I'm going to go back here to my table that I said make sure you know. What are the basic components of a coding compliance, which coding KPI measures effectiveness of coding management? Okay, so when I look at that, that is CMI. Remember, know those 6 things that are there. What are the basic components of a coding compliance plan? You can see that they're still up here. Policies and procedures, education and training, auditing and monitoring. Now, number 5 says, use the data displayed below to calculate the capture rate for the chronic obstructive pulmonary disease. So with that one we're not going to worry too much about, but that's the one where I told you that you look over there and you say, for the 190, we're going to divide let's see, the first thing we have to do is add those up. Add 15, 25, and 30. That's 70. So I added 15, 25, 30, that's 70, that's the total. So I'm going to do 15 divided by 70 times 100, 25 divided by 70 times 100, 30 divided by 70 times 100. So 15 divided by 70 times 100, that gives me 21.4. 25 divided by 70 times 100, that gives me 35.7. And then 30 divided by 70 times 100 equals 42.8. So 21.4 plus 35.7 plus 42.8. That gives me a 99.9 if I was to add them all together. No, that's not right. Oh, you know what I did? I shouldn't have added the 42.8 because it says capture rate for the chronic, what is the CC, MCC, so I only have to add 190 and 191. I was thinking that seems really high. That gives me 57.1 for the CCs and the non-CC. So for 192, I didn't even need to do it. Just because that 192 did not have any CCs. It says without. So that's that one. The answer to that is in the back if you'd like to see it written out. All right, the next part of this chapter is about CDI, or Clinical Documentation Improvement. And these are programs that strive to initiate the review of the documentation. It can be retrospective after their discharge, or it can be concurrent while they are in there. It's a way to improve that documentation so the coders can code better. The CDI team activities are directed to make sure that the physician's documentation is timely, complete, and specific. There are some goals. They are listed on page 241 and 242. And you kind of need to know these. Obtain clinical documentation that captures the severity of illness and risk. Identify and clarify missing documentation or nonspecific documentation related to diagnosis and procedures. Support accurate diagnostic procedure MSDRG assignment that leads to appropriate reimbursement. Promote health record completion during the patient's course of care, which promotes safety. Improve communication between physicians and other members of the healthcare team. Provide awareness and education. Improve documentation to reflect the quality and outcome scores, and improve coding professionals' clinical knowledge. Now you'll see that with these, there's no percentage, there's no review rate like there was with our productivity. So nothing about reviewing it. We're just simply looking at how do we make the documentation better to make it easier for us to code it. So here's the characteristics, and they are listed on page 242, 12.9. It needs to be clear. It states the cause of the symptoms. If there's no cause, then it should say etiology undetermined. It should be complete. The physician has fully addressed the concerns. Their entry is signed and dated. Important, signed and dated. Consistent. All entries are consistent. There's no unexplained differences. Legible goes back to handwritten. Clear to read and decipher. Precise, the details are included. Needs to be reliable. All treatment provided to patient is supported by a valid diagnosis statement. Timely. Remember that there's no way we can rectify something that's late. Late's always going to be late. Next, we have our CDI process. This is figure 12.10 on page 243. So we have record review, we have the query, and then we have our education. Now, this is where it goes through a cycle. We do that initial review the day after they're admitted. We go ahead and we establish an MSDRG. We determine the severity of illness. We determine the risk of mortality. Now, these are going to be updated throughout their admission that may change. We query. Concurring is while the patient's in the hospital. We can query throughout the admission. Unanswered queries can be submitted at the final time of post-discharge, and that can be to help us come up with that final MSDRG. Queries can be electronic, they can be verbal. It can be during our first review, it could be during a subsequent review. Physician education is the third piece. We're going to work with the doctors to help them understand why the documentation is deficient and also understand what is required. We need to educate them about those specifics. So, for example, it lists a couple of examples there. It says if the doctor charts infection present, they need to know that it's specific to what type of infection. Now, the CDI specialist is going to review this several times throughout admission. So it's going to be repeated. Review, query, educate, repeat. Review, query, educate, repeat. Through all of these steps, multiple times throughout their visit. The number of times that that's done is based on the documentation and the circumstances of admission. So the longer they're in the hospital, the more complex, the more reviews we may do. So it kind of is dependent. It's not a universal time, but it's a continuous review, query, educate. Now, our staffing for our CDI, this is usually a clinical information specialist, usually a bachelor's degree, 5 years in healthcare. Credentials are listed there, critical thinking, problem solving, ability to work with little or minimum direct supervision, excellent and accurate writing skills, verbal communication, experience with your medical codes, DRGs, MCCs, and then there are some CDI credentials. They are listed on page 245, 12.2, that you can look at to see what those are, kind of summary of those. Next, we have our CDI performance assessment. So we are looking at productivity, and this can kind of change again just because we have those specialties and length of stays. So each one's going to be unique. We are looking at the accuracy because we need that proper review of the record, making sure we get the correct MSDRG, the SOIs, ROMs. We look at the need for queries, and then we communicate that with the physician. Now, there is something that's called a review rate, and that review rate is a formula that's part of our metrics. If you look over here on the next page, table 12.3 in your textbook, it says this table provides CDI metrics and their description. So the very first metric is a review rate. It is total discharge review divided by the number of discharges available to be reviewed. So let's say that I reviewed 150 and there were 200. So I would say 150 divided by 200. Grab my calculator. 50 divided by 200. That would be a 75% review rate. You do need to know how to calculate review rate. That's the metric, that's the first metrics on table 12.3 on page 246. So there is some math on this test, and there will be a calculator. Next, we have figure 12.11, which is the sample CDI dashboard. This is our dashboard for our CDI, similar to what we had whenever we did our coding, but we're just not looking at as many areas. AHIMA does have information that will help with CDI programs and standards and reviews. So our last slide is to look at our patient connection, which is on page 247. It says Sierra is a CDI specialist at Memorial Hospital. She's been assigned to the orthopedics unit, and she reviews medical and surgical visits daily. She writes a query to the physician asking him to document the reason for the IV antibiotics in the medical record. So I'm going to look on page 247 and see if it gives us a little bit more. So she continues to follow after day 2. On day 5, she reviews the records and notices that a wound culture was taken because the surgical site is red, sore, and weeping. Dr. Shaw orders to start IV. Sierra writes a query to ask him to document the reason. So what we should be getting is something back from that doctor that talks about where they cultured that wound. So Dr. Shaw receives the CDI query on day 6. Although the culture results are not ready, Dr. Shaw remembers that during CDI training it was discussed that physicians should always provide clinical validation for treatments. Therefore, Dr. Shaw documents suspected bacterial infection at the surgical site to provide clinical validation for why the IVs were ordered. When the lab results are released, Dr. Shaw will confirm the results in the medical record and list the type of bacteria at that time. So that's just a little example of the CDI. All right, that is our big PowerPoint. So now, we've got a couple of those little ones that I like. So let's close this. Let's look at number 1. So this is our number one. It's all about coding management, query. It talks about the three parts of the performance assessment, productivity. Remember that each one of these factors is a category. Know what falls under each category. Here is that example of how to calculate. That was in our text. Accuracy. Remember, accuracy has diagnosis, procedure codes, modifiers, and that discharge status. Remember that the discharge status is what tells us where that patient's going when they are discharged from the facility. You can go through and read. There's about query, the criteria, those that we looked at, 12.5, 12.2. Remember, we need these characteristics. You need to know those. All right, so there's that one. Now, then let's look at our CDI one. There's our processes, review, query, educate. Remember that goes on until everything has been covered. There's our productivity, accuracy, those dashboards. Remember, you need to know that first metric there on that one. Review rate, there it is. Total discharges reviewed divided by the number available. That is on your test. There's the dashboard. So there's that. And then the last thing that we have to look at is actually what we would submit to our leadership team if we were doing a CDI performance assessment. So you can go through and look at that and see how we would report that and how we would write that up in each one of the areas. So that's just an example if you had to write up a performance assessment for CDI, how you would do it. So that is chapter 12 in the revenue cycle.